Good afternoon, everybody, and a very happy New Year. Thank you for joining us for today's webinar. It's our pleasure to welcome Dr. Nupur Gupta to the program. She'll present on implementing telehealth consultations for infectious diseases and HIV. And we'll have time at the end for discussions and questions. We have a few introductory slides and housekeeping slides. And today, I'm Leka George, and I am joined by Max Richards, Laura Rowald, and Ruby George. And over to you, Laura.
All right. This educational activity is a project of the Texla Telehealth Resource Center, a federally funded program with F. Marie Hall Rural and Community Health at TTUHSC and Well Ahead, Louisiana. And we received generous support from HRSA, which is Health Resources and Services Administration. CME credit is available for participants of the webinar, and a link to take the survey will be provided at the end of the presentation, as well as emailed out to attendees. If you did attend our December program as well, CME credit will be available to you for one of the two events.
These are just some helpful tips for our webinar and for ensuring you can receive CME credit if so desired. Please make sure everyone's muted. Please type any questions or comments you may have during the presentation into the chat box. Dr. George will now introduce our distinguished speaker.
Dr. Nupur Gupta did her undergraduate in microbiology at UCLA and then completed an MPH in epidemiology and then graduated in Doctor of Osteopathic Medical degree at the Midwestern University in Phoenix, Arizona. She completed her internal medicine residency at Allegheny Health Network in Pittsburgh. And then following that, she did her training in the Infectious Disease Fellowship with a focus on HIV and AIDS at the University of Pittsburgh. She has been a faculty member in the Division of Infectious Diseases at UPMC since 2019 and currently leads their telehealth HIV care efforts. Dr. Gupta received the Quality Improvement Research Award in 2019 at the University of Pennsylvania Medical Center Physician's Excellence in Clinical Care Award in 2023. Now, we are excited to see what she's going to achieve. We are honored and also to have her today. And I give it to Dr. Nupur Gupta to continue with this wonderful lecture.
Thank you very much. And I will share my screen and my slides. Just give me a second. And could you confirm if you're seeing the presenter mode or the notes mode?
We do.
It looks like the presentation. Looks great. Yeah.
Perfect. All right. Sounds good. Thank you. All right. So I will get started. So good afternoon, everyone. Thank you very much for the kind introduction and the invitation to speak today. I'm excited to share with you the implementation of infectious diseases and HIV telehealth consultations. It's a topic that's near and dear to my heart because I believe it really has the potential to be a great health equalizer. Feel free to ask questions during the session by typing in the chat or unmuting yourself, or at the end as well. All right, and I do not have any financial disclosures. All right, so our learning objectives today, they'll consist of discussing the indications, advantages, and applications of telehealth and ID. I will attempt to elucidate how to leverage technology in infectious diseases cases, and we'll also explain the special considerations and logistics that entail the implementation of such a program by your facility. So I will start here with a learning case that I was involved in via TeleID. I think it's a really good illustration of the spectrum of care and management that TeleID can provide and also lead to good patient outcomes. So our chief complaint here is that I feel short of breath. This is a Spanish-speaking woman who's in her 50s, and she had presented to our hospital with multiple complaints on her review systems. She reported 3 to 4 months of shortness of breath, abdominal pain, dysphagia, diarrhea, chest pain, and night sweats. These, however, acutely worsened in the last few days, thus leading to her emergency room visit. She also reported at the same time that she's had an unintentional weight loss of about 30 to 35 pounds over the last 3 months. Her other histories, including past medical, past surgical, they're highly unremarkable. She has no allergies and she doesn't take any daily medications. Her social history consisted of she had immigrated from the Honduras to the United States in 2010. She has been living in Michigan since then with a male partner for the last 7 years. They had separated recently, however, and she has not been with any other partners since then. She subsequently moved to Newcastle, Pennsylvania, which is in the most western part of our state here, to be closer to family. This was around 2021. She has no exposure to any pets at home, no other travel than what I already reported, no illicit substance use. She believes she had the BCG vaccine when she was younger, as this will become important later in the case. And she used to work in a meatpacking plant while living in Michigan. On this map here, you'll see that this is where Newcastle is located, again, on the most western part of our state. And here is where we are in Pittsburgh. So they're approximately 50 miles or about 1 hour driving apart from each other. In Newcastle, we have a smaller community UPMC hospital, and which is where this patient had presented. And this is also where we have an inpatient tele-ID service. So on the initial documented exam, as you can see, she was febrile, she was tachycardic and tachypnic. Her oxygen requirement was 8 liters and she was only satting 96% on it. Her initial documented exam was mostly unremarkable, but she was in some mild distress. Her labs on presentations showed anemia, a thrombocytosis. The metabolic panels showed an acute kidney injury, and we had no prior labs available on this patient for comparison. Her liver enzymes were unremarkable. She had an additional microbiological workup done as well, which included blood cultures, COVID, flu, RSV swabs, as well as stool culture, C. difficile PCR, and an ovine parasite screen, which all returned negative. She did have a CAT scan of her chest, abdomen, pelvis done, which did not show any pulmonary embolism, but was significant for a bilateral lower lobe consolidation and opacities in the upper lobes that was compatible with extensive multifocal pneumonia. And this is the image or one of the cuts of her CAT scan. And as you can see, those consolidation in the lower lobes and the opacities in the upper lobes. It was also significant for some diffuse esophageal thickening, which should be clinically correlated with esophagitis and pancolitis as well. So at this point, a consult is placed to our tele-ID service at this hospital. This hospital has no in-person ID service, and the reason for consult is pneumonia. So before I go into our tele-ID consultation and management for this case, I'd like to take a step back and discuss what exactly is tele-ID and how do we do it. So infectious disease as a whole, we've been ahead of other specialties when it comes to utilizing telemedicine. And as you'll see through this presentation, we have been using it in a variety of settings within our specialty with good results. So what has really helped, I think, in our specialty is that even our professional society, which is the Infectious Diseases Society of America, or IDSA, has been very supportive of its use, even before the rest of the world discovered its use during the SARS-CoV-2 pandemic. In their position statement, which came out in 2019, this was authored actually by the director of our ID telemedicine at UPMC and a founder of a ID Connect, which is a telemedicine company, which I'll discuss later, Dr. Rima Abdelmasi, they write that they support the appropriate use of technologies to provide evidence-based, cost-effective subspecialty care in various areas of infectious diseases. And this paper further goes on to provide insight on what considerations you might make when trying to implement such a program. Infectious disease, as we know, it's an integral part of hospital medicine and outpatient medicine, and this was highlighted even more by the pandemic. But even before that, there has remained, an unmet need for ID care. So despite a huge, vast availability of great training programs, there is still a big ongoing shortage of ID specialists. Unfortunately, many of these programs go unfilled, as highlighted by our match this year again. But this becomes even more apparent at community hospitals and rural areas that lack any sort of ID presence in their surrounding area. So as our patients age, they live longer, and then they carry more complex medical diagnoses that potentially require specialist care, especially from infectious diseases. These community hospitals are forced to transfer their patients to tertiary care facilities, which not only impacts that patient's life, but it also impacts the hospital's ability to generate revenue, and it affects their local and national reputation. Dr. Walensky and colleagues, so they looked at actually where is ID in COVID back in 2020. They found that almost 80% of United States counties had actually either inadequate or no ID physician expertise at all. So approximately 208 million US citizens don't have access to any ID specialists. It's certainly challenging to recruit and retain specialists in rural and community settings. But based on this map, if you look, there are also many urban areas where large academic medical centers are located. And even these don't have enough ID physicians to provide the necessary care to their patients. Lastly, they also found that about 81% of US counties that had the highest proportion of COVID-19 cases at that time of the study, they had minimal to no ID physician coverage. So this shortage that we're seeing of ID physicians, it'll persist. So we have to find, innovative ways to provide care with what we have. When it comes to providing HIV care in rural settings, there are additional challenges to consider that are maybe slightly different from just general infectious diseases and besides the just the ID physician shortage. Despite it being 2024, there is still a lot of stigma surrounding HIV, and unfortunately, our patients suffer for that. There are confidentiality concerns, as these are small communities where everyone unfortunately knows each other's business. So patients in these areas, they generally lack access to providers and specialty services, including Ryan-White funding, which is a federally funded grant that is a great support and network for these patients, especially when it comes to being able to afford and cover the cost of their antiretroviral therapy, because as we know, those can be highly expensive. And a common barrier to HIV care in these communities that I often hear about is transportation. Getting to their appointments, getting their labs drawn, especially in areas that might lack public transportation, it becomes a whole day for many of these patients. So we have to evolve our way of providing care and meet these patients where they are. One way that ID has truly evolved their specialty and combat this physician shortage is obviously by utilizing telemedicine. There are various ways in which we can conduct telemedicine. So one of the ways is through an asynchronous provider-to-provider method through an electronic consult. And these can be done inpatient or outpatient by documenting directly in the electronic medical record after a brief chart review to answer usually a specific question that the provider has. It generally doesn't require a conversation with the patient, but can be done if so desired. And this is a billable process. So, and then the second method that we have, it's a synchronous provider to patient method. So these are audio only phone visits. Many of us have probably been doing this during the pandemic and continue to do so. They are, good methods, I believe, for check-ins and medication management. But as we know, they are certainly limited by exam, and we may not be, and right now we can still continue to bill for them to the end of 2024, but after that, it still remains to be seen what's going to happen. The third method that we use that we're all intimately aware with are video to home audio visits via whatever the application of your choice might be. At UPMC, we use software called VidBio, which is built into our Epic electronic medical records. And these are helpful visits, right? They are billed similar to in-person visits as well, but they're limited, again, by exam, and the patient also being able to have access to the internet or to a phone or to a tablet to be able to conduct the visit. Lastly, we also utilize synchronous provider to provider or provider to patient visits as well, to the use of live inpatient audio video visits or live audio video visits at a freestanding telemedicine center. So both of these types of visits, what they require is a telepresenter who's usually a trained registered nurse at the other end who's with the patient while the provider is at the originating site, for instance, in Pittsburgh. The telepresenter can help with, making sure all the equipment is working correctly and with actually conducting the full exam. The patient does not have to worry about connectivity issues because they'll have access to that either at the hospital or at the outpatient telemedicine center. So these types of visits, they're great because these are the closest that we can get to a face-to-face visit, but certainly they're a little bit more challenging to implement because of the additional logistics required. And so they're not as readily available for most people. Utilizing these forms of tele-ID that we have, so we've already been using them in various aspects of infectious disease, including, for instance, in our HIV care, mobile health interventions that we do, such as text message reminders. That's a form of tele-ID. In the management of tuberculosis, we have been doing electronic directly observed therapy and doing check-ins for instance, side effects of the medications that we use. We have, wonderful antimicrobial stewardship programs at hospitals and post-acute care facilities now. And they are able to provide case consultations, review of antimicrobial use and antibiograms, and provide direct feedback. In the world of outpatient parenteral antimicrobial therapy, when patients go home on IV antibiotics, these patients often live far away from that original hospital where they were admitted, but they still need close monitoring of their infection to prevent any worsening or prevent a readmission. So this is where telemedicine can again be a great check-in method. And then in the world of infection prevention and control, especially at post-acute care facilities who suffered a lot during the pandemic, they need assistance in infection surveillance, monitoring for outbreaks, and providing education, which can all be done via telemedicine. And lastly, this Project Echo, like what we're doing here today, this is a great example of telemedicine because it enhances knowledge and provides education, right? There's several advantages to telemedicine, including in our tele-ID world. I won't go through all of these because these benefits are well known and they're well realized. But just suffice it to say that telemedicine, I think, has really improved access for those who are restricted via geography or disabilities. And although there are several drawbacks, including logistics, exam, I still think of it as like a win-win-win situation because the provider wins, the patient wins, and so does the health system. So how has UPMC really utilized these various forms of tele-ID for our outpatient and inpatient care? first, let's look at outpatient care. So historically, Medicare has covered telemedicine services, but only by very specifically defined geography. So for instance, only in areas that are called rural health provider shortage areas. In 2019, they expanded the types of virtual visits that could be covered, but these were very challenging to operationalize because of complicated rules. But UPMC, has been kind of ahead of the game again. So in addition to it being a large health system with over 40 hospitals, spread out over multiple states, it also does have a health insurance arm. And so in 2019, after some pilot work, they started to encourage all their providers to across all specialties to do video visits while they were reimbursing for these visits at the same face-to-face visit rates. So we started doing these in our infectious disease clinics for both general ID, for OPAT, for HIV, well before the pandemic even began. And then, the COVID-19 pandemic hit, and those Medicare rules that had been in place since before, they were temporarily waived to ensure, patient and provider safety. And many of them still continue to be waived even after the end of the public health emergency, at least until the end of 2024. So for many of the providers in our division, pivoting to outpatient telemedicine in 2020 was a very easy process because we'd already had the groundwork in place. So looking specifically at our tele-HIV model. So, we were already doing these video to home visits with our patients since even before the pandemic began, which everyone now does them on a daily basis as well. But we wanted to take a step further, and we really wanted to expand our care model, especially to those who live in rural areas that may not have access to specialists. So our HIV clinic, or the Pittsburgh Area Center for Treatment, or we call it PACT Clinic, it's a Ryan-White funded clinic, so federally funded in the heart of Pittsburgh. So first thing that we did was we began by looking at where the prevalence of HIV is within our surrounding area. So here we are located here in Pittsburgh in Allegheny County. And this is a heat map from 2019 of HIV prevalence by the surrounding counties near Allegheny, where we are. So areas in red, those are the areas that generally have the highest prevalence of HIV. Because, when you start kind of getting outside of Pittsburgh, many of these areas do become, fairly rural. And so patients that live here, they may not have access to internet, they don't have the best connectivity or even access to smartphones or tablets. So we knew, getting these patients to do video to home visits may not be the best way of reaching them. And they're certainly not going to be able to travel to Pittsburgh because of the barriers that we discussed before. So we found that actually UPMC has those so-called freestanding telemedicine centers, which are built just like a regular brick and mortar clinic with individual exam rooms. But the difference is that the patients come to the clinic, and with the assistance of a telepresenter, we see them from a distant site, and where the provider is located here in Pittsburgh. So UPMC has several of these scattered throughout the state, and we picked 3 areas that are circled here that coincided also with the prevalence of HIV in those areas. We started seeing patients at all 3 of these sites in 2019, and I call it, local yet global care, because they have access to more care while they stay in their community, which they otherwise might not have had. And having a telepresenter there, it really allows us to conduct a full head-to-toe exam, and we can listen to their heart and lungs using a Bluetooth stethoscope as well. We work with local case management to provide them Ryan-White services as well. In the situation where I've had some patients who are, primarily homebound. So what we do is we can actually do a mobile telehealth suitcase. So that same telepresenter or the registered nurse can actually take all the equipment that we use to do the telemedicine visit from that outpatient center, so including your laptop, stethoscope, camera, internet hotspot connection, we take all of that to the patient's home and do the visit directly from there. The other nice part is because they're a registered nurse, they can also do lab draws, so it becomes a mobile lab draw at the same time. So we have about 40 or so patients that we've been able to retain in care who otherwise, might not have been in care somewhere. Their viral load suppression rate is over 90%. And the nice thing about these centers is that other specialties also utilize them, which is beneficial for the patients and the health system. So there's more incentive to keep them around. Our tele-ID model, however, is slightly different. So like with outpatient tele-ID, UPMC has been ahead of the game for inpatient tele-ID as well. So since about 2014, our ID division in Pittsburgh, we've been doing telemedicine at various UPMC hospitals around the state, including for the case that I presented earlier. These hospitals generally have had either, single in-person ID physicians, or they've never had any ID access at all. So using the same concept as we do at the telemedicine centers, we have a trained telepresenter who helps us round to, see the patient, chat with them, and conduct the exam and discuss the plan. The notes go in the same electronic medical record, and we can also chat with the provider. The telepresenter, moves the computer on wheels to them. So in addition to that, we have those following up on those IV antibiotics or OPAD clinics for patients who are discharged from these hospitals at nearby telemedicine centers as well. So it's comprehensive care and keeping that patient in their community. And then in 2019, Dr. Abdul Masi, our director for ID telemedicine, along with our chief of ID, they worked with UPMC to form a company called ID Connect to oversee all the telemedicine services that the division provides. This company actually became its own separate entity and was able to take that same telemedicine model that we've been doing to other non-UPMC hospitals really across the country. Many of these hospitals are located in smaller, more rural areas who have never had ID before, but they're also at some major health systems that who needed to supplement their already existing ID providers because of the high volume that they were seeing. The ID providers are, who do these consults, who are part of this, they're part of this UPMC ID division, so they're employed through UPMC. Many of them only do telemedicine, while some are hybrid, such as myself. So we do both in-person and telemedicine rounding. We have an ID physician who's assigned to each telemedicine service which consists of usually rounding at either one or multiple hospitals during the day. And they rotate on these services for a week or 2 weeks at a time, just like our in-person rounding schedules. In addition to telemedicine, ID Connect also provides tele-stewardship, OPAD services, and infection prevention and control to many of these hospitals as well. So this partnership has really been a boon for patients, providers, and hospitals who now get to keep their patients in-house instead of trying to transfer them. We can take these new models of care everywhere, but does ID really hold up its end of the bargain and improve outcomes? And there have been actually several studies that highlight the importance of having an ID specialist on board early because they improve several key patient outcomes, including length of stay, discharge to home, and lower readmission rates. With having ID specialists on staff, hospitals also experience fewer nosocomial outbreaks, decreased rates of hospital-acquired infections, better use of antimicrobials, reducing toxicity and cost of them, and decreasing the microbial resistance rate. But again, this has all been found on the basis of providing in-person ID care. So is tele-ID capable of achieving similar outcomes? And we actually tried to prove this because we have a lot of data from all the telemedicine services that we've been providing for a long time. So we actually did a retrospective study at 3 of those same community hospitals that we serve that previously had only in-person ID care until that physician left and tele-ID took over in 2018. So the same in-person ID physician served 3 hospitals, hospital 1, 2, and 3, that were about 1 hour and 40 minutes driving apart from each other. Hospitals 2 and 3 were combined here because they share the same EMR, and they also have the same management because they're much smaller. When the in-person ID physician left and Tele-ID took over, we started doing live audio video visits, electronic consults, and telephonic curbsides as well for 2 providers directly. So the patient characteristics here in the first part of the table, they're fairly similar in terms of race, age, sex, and body mass index, as well as your Charleston comorbidity index. However, Tele-ID was able to do significantly more consults at all 3 hospitals over a 6-month time period when compared to in-person, presumably due to having the elimination of travel time that was required to go between these 3 hospitals. The other outcomes that we looked at, including length of stay, ID-related readmissions, transfer to tertiary care center in Pittsburgh, discharge to home, and mortality rate, although they were not statistically significant, but they were lower when looked at in the Tele-ID group. So although Tele-ID is not better than in-person ID, it certainly is an effective alternative, especially when it comes to rural areas. And we actually looked at academic centers as well. So during the first few months of the pandemic, when little was known about it, this is between March through the end of May 2020, we also transitioned to doing telemedicine in our main flagship hospitals in Pittsburgh, where we traditionally only had in-person care. So we did live audio video visits, phone visits, and electronic consults. Patients could have been seen in person, so we excluded those consults for the purpose of this study. Given it's a tertiary care hospital in Pittsburgh, we have multiple ID services, and our general ID group here also includes any of the surgical consults that we might have gotten. And then we separated that from our transplant ID services. Here are the patient characteristics and the number of consults that we saw in each group via telemedicine during that time period. And what I really want to highlight here, though, is look at the number of transplant patients that we saw and the type of transplants that they had. Many of these included our stem cell transplant patients and our patients who were receiving CAR T cell therapy. So these are complex and they're sick patients, and they were exclusively managed via Tele-ID. In the table on the left, you'll see the primary outcomes for all of the Tele-ID cases seen by both services. And as you can see, hospital length of stay was short, rates of in-hospital mortality or 30-day mortality, readmissions, they were all fairly low. And then what we did was we set out to compare these Tele-ID cases to in-person ID controls from a year before, that is pre-pandemic. So we were able to match approximately 65 of the total Tele-ID cases based on exact ID diagnosis, age, sex, race, and their comorbidity index. We found that compared to matched in-person controls, Tele-ID demonstrated a significantly lower 30-day readmission, as well as a shorter ICU length of stay. Part of this could have been because we wanted to make sure that these patients got out of the hospital in a safe and quick manner because we didn't know much about the pandemic as well. But, if push comes to shove, Tele-ID is also a good alternative, not only for community hospitals, but also for large academic medical centers. And lastly, what I want to show is that, it certainly isn't easy to implement live audio video visits because of all the logistics involved for the inpatient side. So what about using just electronic consults, which are done asynchronously from provider to provider? So we looked at this as well, because one of the hospitals that is part of our UPMC health system, they have a single ID physician who is in person, but they had to be unfortunately away for several months due to extenuating circumstances. And so Tele-ID provided care through electronic consults only during that 3-month period while they were away. We had a total of 121 encounters during that period, and our total length of stay post-ID consult was low. Most of them, again, were discharged home. Rates for tertiary care hospital transfer to Pittsburgh referred was low, as was mortality and readmission for ID-related infection. We also actually looked at the ID diagnoses that we made during this time period. And as you can see here, they were fairly broad, the majority being for bacteremia, skin and soft tissue infections, and bone and joint infections. So, we could manage a variety of cases without ever seeing or touching the patients and still had good clinical outcomes. And so though there's limited data, there's still been a lot of published data on the use of tele-ID in various settings, and they've shown similar outcomes like our previous data. So there is, a really strong emerging data and evidence to support the continued use of tele-ID. In regards to tele-HIV, we haven't yet studied, the full patient outcomes for the persons with HIV that we see at our telemedicine consult centers, but we did look at the impact of video to home visits as well as audio-only visits on retention and care and virological suppression. We found the rates for these types of visits pre and during the pandemic, so 2018 to 2020, were relatively the same, around 60% or so. However, there was a steep drop-off when it came to preventative care, such as sexually transmitted infection screening and influenza vaccination rates, especially in 2020. And this could certainly be due to patients not feeling comfortable, coming into the clinic during the height of the pandemic. We also found that the rates of virological suppression was higher when those who had a telemedicine visit and an office visit during the calendar year 2020. So even though, most of these patients are probably still taking their antiretroviral therapy, but this data is also going to be affected by patients going in for a lab draw for their viral loads. So telemedicine helped, but only to a certain degree. In regards to the published data surrounding this in the literature, there's been several additional studies looking at telemedicine use in clinics that serve people with HIV, including in their prison system. But the results have been mixed. Some found a benefit in terms of retention and care, while others have had, found that their virological suppression rates suffered, like in our case. The study looking at telemedicine in the prison system found that they had improved viral suppression rates, but could this be because they're located in one place and can have their labs drawn? There have also been a lot of studies looking at mobile health interventions, which have also produced mixed results. I do also want to highlight that the Health Resources and Administration, or HRSA, that provides the Ryan-wide funding for the programs across the country, they recently had actually a call for grant applications to better understand the use of telemedicine amongst persons with HIV and how to maximize it. And gratefully, we're one of the 5 sites that are included as part of this grant. And so hopefully in 2025, we'll be able to get a better answer on who uses telemedicine amongst persons with HIV and what their thoughts are about it. So now that we hopefully have a better understanding of how telemedicine works and what it has to offer, let's go back to our real life case and how it affected its management. So just in summary, this was a Spanish-speaking woman in her 50s who had multiple complaints, including shortness of breath, dysphagia, chest pain, abdominal pain, diarrhea, night sweats, and weight loss. She was requiring 8 liters on nasal cannula. Her chest imaging was concerning for pneumonia, and her abdominal imaging showed evidence of esophagitis and pancolitis. So the way our Tele-ID consult service works is once the consult is placed, we follow that patient throughout their hospitalization or until we sign off, like an in-person rounding. We triage on a daily basis, whether we'll see the patient through a live audio-video visit, or just do an electronic consult, which includes a review of the chart only. Both of these methods are applicable to either the initial consult or the daily follow-ups. Again, the live audio-video visit is conducted with the aid of a trained telepresenter. And because this patient was Spanish-speaking, we had to use, we used Translator on the Seracom app, which is a language services company that UPMC contracts with, who was on a tablet at the patient's end, but we could use the audio-video modality to communicate as well. The daily notes and orders are placed in the same EMR, and communication with the team occurs either via phone, or if we're doing a live audio video visit, then often we'll run into them while rounding with the computer on wheels. So at Tele-ID's initial consult visit, the patient's exam was notable for coarse breath sounds throughout all the lobes, as well as oral thrush. So given her presenting symptoms, her imaging results, and the presence of oral thrush, there should be one diagnosis that immediately jumps to the forefront, which is advanced HIV. The imaging results were also suspicious for pneumocystis jirovecii pneumonia, and the oral thrush, along with the dysphagia, the findings on imaging, raised a flag for Candida esophagitis. So TeleID had several recommendations, which were check an HIV screen, which unfortunately came back positive. Her viral load was just over 500,000 copies. Her CD4 count was, however, fairly low at 37 and 2%. Cryptococcus antigen was negative. We were given from where she had immigrated from and her imaging results, we did place her in isolation to obtain 3 AFB sputum samples to rule out tuberculosis, which came back negative, and incidentally, her quantiferon gold was also negative. She was started on trimethoprim sulfamethoxazole and oral prednisone for suspected PJP pneumonia, and her beta-D-glucan was also positive, again supporting our diagnosis of PJP pneumonia. She was started on fluconazole for Candida esophagitis, which was actually also proven on her EGD. She also had a colonoscopy, which was largely unremarkable, but given the pancolitis, she had MAI blood cultures and stool cultures done, which also came back negative. Her screening for hepatitis B and C were unremarkable, and she was started on antiretroviral therapy as well. So the plan on discharge by ID was to, complete her 21 days of Bactrim, followed by prophylactic dosing, giving her a low CD4 count, continue her 21 days of prednisone taper, and then complete the 21 days of fluconazole for Candida and continue her antiretroviral therapy. And social work was at the hospital, was able to connect her to a local Ryan White case management service to help manage her finances as she was uninsured. But now the question came up, where is she going to follow for HIV care? So the hospital where she happened to be admitted was thankfully connected in Newcastle to one of the telemedicine centers where we also hold our monthly tele-HIV clinics. And since her family wouldn't be able to drive her to Pittsburgh for the visit, we arranged for a follow-up there within 1 week of discharge, where we again use the same modality as we do inpatient for live audio video visits, placing the orders and notes again on the same EMR. The local hospital has an outpatient laboratory where she could go for her lab draws. We were able to connect her to a local primary care physician and also connect her to actually a registered dietitian in our brick and mortar packed clinic in Pittsburgh for nutrition support given her weight loss, and they can check in via phone. And, as you can see, she's had successful retention and care as evidenced by her biological suppression and her immunological control of her disease as well. So, successful implementation of a TeleID program with various applications and with good patient outcomes is certainly possible, but there's several considerations that need to be made before taking this on. This graphic is from that same IDSA position statement that I showed before, and it highlights several of the key issues to contemplate regarding TeleID. This includes patient engagement and thinking about your population that you plan to serve and the providers that will be involved. Are they going to be comfortable with TeleID? What types of cases would you use TeleID for? Do the patients have access to technology or do they need it? Is there a way to use translators, like in our case? Thinking about communication, how and where will you document? How will the recommendations be communicated to the primary team? What is the process for if an urgent or emergency thing happens to pop up while you're in a telemedicine visit? How will you manage that? In terms of the clinical model, what forms of TeleID will you offer and for what indications again? And just as importantly, and probably more importantly, we also have to consider the business side. Regulations regarding licensure and credentialing, they vary widely on a state-by-state basis. We also need to understand the reimbursement process, so which types of visits can be billed, who can bill, meeting with your lawyers. It's an important step because you have to understand the liability involved, right? So for instance, if I answer a curbside question while on TeleID, am I responsible? Or if I only do an electronic consult without ever seeing or touching the patient, what is my liability risk? And will that medical liability insurance policy that I'm covered under, will that also cover telemedicine? And lastly, HIPAA requirements must be met, and all interaction should be confidential, right? So the type of hardware and software used to conduct these visits should be encrypted and secure. Thus, when utilizing technology for telemedicine, the burden really lies with our practitioner or the organization at the distance site to ensure that everything is up to code. And lastly, I'll leave you with this checklist that was actually recently published in one of our IDSA journals. It was authored by many of the folks who lead tele-ID programs around the country, and it's a checklist on how to implement, a tele-ID program. It outlined several phases, including pre-implementation, implementation, and sustainment, and the steps required at each phase for having a successful program. So the most important step really is pre-implementation, the planning that goes into it, because the first and most important thing is to secure support from leadership and identifying who are really going to be the champions of your tele-ID program, because these are your stakeholders, right? And when engaging with them, you have to consider, all the different metrics, how many patients will get transferred, how much is spent on antibiotic, who interprets the microbiological results, developing a standard operating procedure that includes strategies to assess known and anticipated barriers. That's an important step in pre-implementation. And actually this paper has a nice table on a lot of the barriers to consider and how you can go about overcoming them as well. Addressing all the practical considerations, which really include all the licensing aspects, credentialing, liability, and training. And then lastly, having measures or evaluation measures to assess how your program is working once it's implemented. So these could be things like looking at number of ID consults, how long do it take to complete the encounter, perceptions of quality, antibiotic use metrics. I would suggest it's a really good idea to have this in place before starting the program, because as we learned in our program, going back for the chart reviews and understanding how our patients did and how we did as providers, it's an arduous process. And then once you have implemented the program, set a timeline for it, reporting the progress on it and reconvening with those stakeholders on a regular basis. It's important to review your evaluation measures and refine your process as you're moving through it. And lastly, the key to any program is sustainability. So this is where those evaluation metrics really come in handy, and we can figure out how this program can be maintained. The nice part about this article is that it goes into further depth about reimbursement measures as well, specifically in infectious disease and tele-stewardship, along with discussing all the potential barriers. And it also talks about how to add a antimicrobial stewardship program in conjunction with a tele-ID consult service. So some of the take-home points that I hope you got from this talk, when in doubt, it's always a good idea to have ID on board because we can help improve patient outcomes. There is currently a huge shortage of qualified ID physicians in many of our areas in the country, and we have to be creative. So tele-ID is an alternative to the standard brick and mortar care that we've consistently provided. Both tele-ID and tele-HIV have strong applications in telemedicine, and they've proven themselves to be just as effective as the current standard of care. And before implementing these types of programs, we have to have several considerations that need to be made, but I think success is certainly possible with early engagement from all of your stakeholders, as well as through careful planning. And I thank you for listening and for the invitation to speak today. I can certainly be reached at my email address listed here, and I'm also happy to take any questions.
Dr. Santos is the director of the Project Echo series at Texas Tech, and he's a trauma surgeon. And today he could not be in person to ask to be here and to be part of this program. But I invite Dr. Santos to ask his question. He's eager to find some. He does have a lot of questions to ask. Go ahead, please, Dr. Santos. No? Okay, I can ask him.
Maybe.
Okay, looks like Dr. Santos has dropped off, so I can ask the question that he had. Okay, I'm sorry. With regards to how do you compliance of the patients? Like, these are patients who have chronic conditions like tuberculosis and everything. So how do you monitor their compliance?
So monitoring compliance is challenging for, I think for any chronic disease or any acute or chronic disease, right? But the way we try to do it is, a couple of different ways. So obviously, if we're seeing them in the hospital, we try to, really emphasize the importance of following up with us, and we try to make sure that they have an outpatient follow-up scheduled even before they've been discharged from the hospital. And then especially if they're going home on intravenous antibiotics, then our OPAT program is excellent in that we have a dedicated team who can reach out to the patient and check in with them, but also then schedule them for a follow-up visit with us, so we can ensure that at that visit that they've been compliant with their medications, that their care has been consistent. So it's really, I think, thinking kind of ahead before the patient even leaves the hospital, that they have something in hand and that they have follow-up already scheduled with us.
So I was very intrigued by this mobile telehealth suite. So how do you get the patients to come? Because how do you decide ahead in advance where you're going to and what locations do you pick for this kind of a program?
Sure. So the way that we picked our telemedicine consult centers, where we provide, tele-HIV care, that was really based upon looking at where the prevalence of HIV, for instance, is in our surrounding area outside of Pittsburgh, and then looking at, what does UPMC already has to offer, and one of those was those consult centers. So it's not like we had to go out and build those centers. Thankfully, they were already there, so we just had to take advantage of those. And what we did really is, one, we advertised. So we spoke with local primary care physicians. We put up, flyers in places where patients with HIV might visit. We worked with local Rhine-White case management services to advertise this program. And so that's how we were able to get the word out about those freestanding clinics. And once the patient decides that, hey, I need to have an HIV provider, they actually could just contact our UPMC Center for Scheduling, like essentially or either the main central scheduling number or directly contact our clinic to make an appointment. So our schedulers are aware that these clinics exist and they can schedule them directly in those centers. So they can come there and be seen by the provider who's in Pittsburgh. In terms of the mobile telehealth suitcase, the way we decided on that is usually it's done with the help of our local Rhine-White case management services, because they're in the community. They know which patients are, who are homebound, who may not be able to make it to that telemedicine consult service center, because usually they're the ones who are providing the transportation to those patients for their other appointments, labs, other diagnostics and things. So we worked with them because they knew who those patients were. So they could tell me that, hey, this patient is not going to be able to come to the clinic. We have to take the clinic to them. And so that's how we decided, this patient, this is how we're going to do their follow-ups in the future as well. And so on that same half day where I will see patients at the telemedicine center, we'll have dedicated time, like usually after the clinic is over, where that same nurse who helped me with the telemedicine center, she will take all that equipment to the patient's home, and then I can log in on my end and we can complete the visit.
Just for understanding, reimbursement is part of sustainability of a program. So how do you manage this reimbursement in such a kind of a scenario?
Yeah, so it's that topic comes up often, right? So for our patients that we see through, for instance, via tele-IDs or inpatient tele-ID services, this is a little bit different because all of those contracts with the hospital who utilize our inpatient tele-ID services, they're managed by the company that Dr. Abdelmasih formed with ID Connect. So essentially they're, doing like a package service where, they'll, it's the hospital's job to essentially get reimbursed for that consult that Tele-ID provided, but they're paying us like a package cost for providing consult services along with any other additional services that we might provide to the hospital. So for the physician, we don't actually charge for any like RVUs, like we don't get any, reimbursement or RVUs for that. We just get a set salary for seeing those patients at those facilities. For the patients that are seen outpatient at the telemedicine consult centers, for example, they're billed just like our regular telemedicine visits, which are reimbursed usually at the same rate as face-to-face visits.
Wonderful. Yeah. Thank you. For anybody else have questions for this? Okay, great. Thank you for this fantastic presentation discussion, Dr. Gupta, and thanks to everyone for joining us today. We would like to present Dr. Gupta with the prestigious Texler TRC Challenge Coin for the wonderful webinar today and for her contributions to the scientific community. It is wonderful to have you with us today. Thanks again for joining us, everyone, and have a great rest of the day.
Thank you so much.
Thank you so much.
Bye-bye.